ASGK grant. The academic program which we have been able to continue for the last maybe close to around 15 months uninterruptedly with the help of various GI surgical units in Kerala and the untiring efforts of Dr. Pidambaran. Let's hope to continue it as far as possible. The topic that we have, I think Arun was supposed to join in for a quiz, but since he may be busy in the OT, so we'll start off with the case today. We have a case from Lakeshore Hospital to be presented by Dr. Jazil, DNB resident in GI surgery. I understand it is a pancreatic bleed, a case of a pancreatic bleed, and I pass off to Dr. Dinesh to take over the proceedings of today's meeting. Dr. Dinesh, please.
Thank you, Dr. Joshi. So yet another Saturday evening, and we are all together for the ASGK Grand Round. So without taking much time, I think we'll listen to Jasil. Jasil, welcome to ASGK. I think we'll get going. So can you start your presentation now?
Sir, sure, sir. So the screen is visible, no, sir?
Yeah.
So good evening, respected faculties. I'm Dr. Jasil, as a DNB resident from Department of GI Surgery in Lakeshore Hospital, Kochi. So today in this night, I want to present about 3 patients who has undergone some pancreatic surgery and who had got a post-operative pancreatic bleed and the conundrums associated with these 3 bleeds. So when we think about the post-pancreatic surgery bleeds, and especially when we think about pseudoaneurysms after the post-pancreatic surgery, they are more looks like similar to that of sword of Damocles. They are actually hanging as a sword, hanging over the head of patients as well as the surgeons. So how to intervene, when to intervene, and when not to intervene is actually a dilemma in a lot of clinical scenarios. So let me take you through 3 patients. So my first patient is a 39-year-old female patient. She is a non-case of chronic calcific pancreatitis, and she is getting multiple hospital admissions for pain. And she had exocrine insufficiency in form of steatorrhea, which has been well managed with the pancreatic enzyme supplementation. And she had endocrine deficiency also, which was well managed with the insulin infusion. So the only concern feature of the patient is her serial CA99 measurements were in a rising trend. It was in the 62. So that is what insisted the local hospital doctor to go ahead with a CCT. So this is the CT imaging of the patient. We can see the dilated duct of the pancreas with an atrophic pancreas, and there are a lot of stones in the duct, which is studded with the ducts actually. And when we trace that to the head region also, we can see the lot of stones. So basically, there is diffuse atrophy of pancreas with a lot of stones in the main pancreatic duct as well as the head. And the main pancreatic duct was dilated up to 10 millimeter. But there is no features of inflammation, no mass lesion, and there is no pseudosis. But the only worrisome feature here is CA99. So it's an article which has been published from our own department. So whether the CA99 can be used to differentiate benign and malignant lesions. Actually, if the CA99 value is more than 300, it has got a 100% positive predictive value to become a malignancy. But in these low values like 37 to 100, it will be only 61%. So just because the CA99 value is high doesn't mean that the patient's concerns are of, we have to counsel her that your concern of cancer, concern of malignancy is not true. But our patient has got repeated episodes of pain, and she has got repeated episodes of hospital admissions, which was actually interfering with her day-to-day activities and her job. So we were thinking of going ahead with the surgery, some decompressive surgery. So her preoperative evaluations were done, which are all unremarkable, and she underwent, as per the routine hospital department protocol, she underwent a phase procedure on 28th of October. So the intraoperative findings were, it was hard pancreas with a dilated main duct of 10 mm, which is filled with the calculin. So the postoperative pancreatic fistula risk score was very low. So there is no pseudosis, and the frozen of head coring tissue was negative for malignancy. So this is actually the intraoperative findings. Then she had the initial postoperative recovery was an uneventful one. Postoperative date 1, we have got the low drain fluid amylase, only 60 something. and the pancreatic fluid culture was no growth. She was shifted to STU. On day 2, we removed the Riles tube. On day 3, the orals were started. On day 4, we progressed orally and she passed normal colored stools by evening. On day 5, again we progressed to semi-solids. The Panzynome has been started because she was taking semi-solids. And POD 6, she is on normal diet and we removed the drain. And POD 7, we have discharged the patient. So there is an uneventful, yet another uneventful pancreatic surgery with an uneventful recovery. But on POD 10, that is on 7th of November, we got a call from emergency room by saying that the same patient has came back with a history of melena, and she passed a large quantity of blood, a large quantity of melena with a colicky abdominal pain from the morning. So we rushed to the ER. On examination, the patient looked pale, and pulse rate was around 110. That's the only parameter which is of worrisome, which is there is tachycardia is there, but the BP was well maintaining. The patient complains of abdominal pain, but the abdomen was soft, and the rectal examination yielded melena. So we got a idea that we are dealing with a case of post-pancreatic hemorrhage. As per the definition, we may be dealing with a grade B post-pancreatic hemorrhage, which is an intraluminal one, which is late intraluminal and maybe a mild to severe, mild to moderate type of bleed. So in this scenario, we think about it may be the usual cause of all the usual cause of bleeding after post-operative pancreatic surgery will be a pseudoaneurysm. So as per our literature search, it will be the most common site will be from the gastroduodenal artery, and then it can be from common hepatic artery or from the pancreatic duodenal artery. So we were also in form of this. So what we did is in the ER itself, we started initial resuscitation and we have assessed the patient. So the status of patient at ER is the patient is hemodynamically stable, except there is tachycardia. I am stressing this point. And the patient has got pallor and there is an evidence of intraluminal bleed. Meanwhile, her investigations has came. HP was 8.6. Before that itself, we have started the transfusion. Then the INR was 1.28. We added 2 point of FFP in our transfusion protocol. And the counts were 35,310, for which we added high-end antibiotics. So the issue is, as per our protocol, we followed the patient. We continued with our next level of investigation as a CT angio. So the CT angio, as per here, you can see it is a superior mesenteric artery. So from the superior mesenteric artery, there is a jejunal branch, and that jejunal branch has got a pseudoaneurysm, and there is no active contrast extravasation was seen in that film. So what we think is, in view of there is no active contrast extravasation, we think of considering or continuing with the conservative management, but the patient had got persistent bleeding and there is still hemoglobin drop. So we proceeded with the conventional angio with plus or minus embolization. So this is the first one. It is a celiac axis they have cannulated, the splenic artery, there is no leak, left gastric, there is no issue. This is a common hepatic with the patent GDS stem, there is actually no leak with the celiac axis cannulation. But when we cannulated the superior mesenteric artery, we can see this is the first jejunal branch, this is a second jejunal branch. So when you trace this, the second jejunal branch, we can see a small pseudoaneurysm in this second jejunal branch, but there is no active contrast extravasation. So we did a selective cannulation of the super selective cannulation of the second jejunal artery. So this is a super selective cannulation, and while taking the angio, we got that this is that pseudoaneurysm which is actually coming out of the distal part of the second branch of second jejunal branch. So when you trace this, you can see this is that jejunal branch. This is a pseudoaneurysm, and this is one stapled end was there. This is actually the stapled end of roux limb of the pancreatico-jejunostomy anastomosis. The PJ anastomosis roux limb, it is a proximal part of that roux limb, and this vessel is actually supplying that part of that around some 3 to 4 centimeter of the proximal end of that roux loop of jejunum. So that is of concern of us because this is a finding, this is a roux limb, and this area, this proximal part of the roux limb, that is the initial part of that anastomosis, was actually supplied by this second branch of jejunal artery with the pseudoaneurysm is there. So we think of this because if there is a pseudoaneurysm happens in a mesenteric artery, there is a risk of bowel ischemia. If you go and embolize that vessel, there is a risk of bowel ischemia is there. So how to prevent that? So there are 3 ways we can, by which 3 ways we can tackle the pseudoaneurysm. Number 1, we can tackle the pseudoaneurysm alone by coiling of the pseudoaneurysm itself. Or if there is good collaterals are there, then we can block that vessel or block that pseudoaneurysm proximal and distally so that the feeders to the pseudoaneurysm will get blocked. But it can happen only if there is enough collaterals are there. And if there is not enough collaterals, we have to actually keep ready or we have to maintain the patency of the blood flow. So we can do a covered stents or stent graft so that this pseudoaneurysm will be excluded from the main vessel. So we were thinking about these possibilities. So then we did some literature search. Is there jejunal branch pseudoaneurysm causing GI bleed is actually very rare. Only a handful of cases has been published in literature. One of those causes is a superior mesenteric artery. So it's it's a proximal branch of superior mesenteric artery. There is a pseudoaneurysm. You can block this vessel as a whole. So what they did is a stented graft they have been placed here. And these are the two cases of jejunal artery pseudoaneurysm, which they have done glue embolization of these vessels. And this is another one. We can see there is a jejunal artery huge aneurysm. It's a large aneurysm. Again, a coil embolization of that aneurysm was done. And this is a jejunal artery pseudoaneurysm followed by a tuberculosis, intestinal tuberculosis. Again, the glue aneurysm, glue embolization has been done. But while I retrospectively analyzed the data of Lakeshore experience in the past 5 to 6 years, I could able to identify 5 to 8 cases of jejunal artery bleed which has not been published. So it may we may have to go through all the data again. So in our conventional angiogram, so this patient, I already told there is a pseudoaneurysm, and that vessel is basically, it's an end artery. It's an end artery which is supplying the proximal part of the root limb of the PJ, and the size is only 4 mm. So we can't tackle that aneurysm alone. So for which we may have to block this entire vessel. If we block this entire vessel, definitely there is a chance of bowel ischemia. That is the root limb of the jejunum, the end of the root limb of the jejunum can go into gangrene, and that can lead to post-pancreatic fistula. Pancreatic the bowel necrosis leads to pancreatic fistula and its own complications. Then in order to avoid that, we go ahead with a stent graft. The stent graft is also not possible because the size or the diameter of the vessel was very small. So we were in a dilemma. So we were thinking about we will have two school of thoughts. So the patient is hemodynamically stable at present, and we have got proper resources are available for over the 24 hours. So we thought one school of thought was, why can't we withhold the angioembolization? But the another school of thought is, if you withhold the angioembolization, the patient can go for hemodynamic instability in the future, and there can be a need of multiple blood transfusions were there, so which carries its own risk. So we have discussed that, but as you can see, as per the film, we have withhold the angioembolization for the time being because of 3 concerns. 1, the patient is hemodynamically stable at present. Number 2, we have got a proper resources are available, and number 3, there is no active contrast extravasation was seen on the CT angio. So we have shifted her back to the STU, and close monitoring of vitals and supportive management was continued. So in STU, we can see the hemoglobin was slowly coming down. So on the 9th of November, it has reached 7.8. We gave 1 point PRBC on 9th of 11. And after that, her HP has been improved, and it has maintained almost in a good manner, in a maintained way for 72 to 96 hours. So we have shifted her out of the STU on 13th of 11. And for this past 4 days, this 10 to 13, she doesn't have any episodes of melena, no episodes of hemodynamic instability. So, and the tachycardia has settled. So we thought of, we have successfully done a pseudoaneurysm has been managed by a non-operative or a non-interventional management. But again, on POD 18, that is on 15th of November, we got a call from room that she has passed one more episode of large quantity melena. And similar to that, on examination, patient has got pallor. There is mild tachycardia of 110. Abdomen is absolutely soft, perectal yielded melena, and we arrange the PRBC. So the question comes, what to do next? So before going to that question, what to do next in this patient, let us change the track for some time. I'm going to take you through another patient, which is of patient 2. He is a 75-year-old gentleman. He is a case of ambulatory adenocarcinoma, underwent Whipple pancreaticoduodenectomy. So intraoperatively, there is an undilated pancreatic duct with a soft pancreatic ecotexture. Yes, of course, the risk of pancreatic fistula was high, so the drain fluid amylase of bilateral drains were high, which was almost normalized to on day 7. He had got grade 1 delayed gastric emptying, but we could gradually progress orally under the coverage of prokinetics, and he was discharged on POD 10 with the left drain in situ. And the ultrasound screening before discharge has actually ruled out any major intra-abdominal collections. But on POD 21, similar to our patient, he again came back with 1 episode of hematemesis of around 200 ml and melena for 24 hours. So the examination revealed pallor, and the patient has got tachycardia, but the blood pressure was maintaining. Abdomen was absolutely soft. Rectal examination yielded melena. So as per the protocol, we started initial resuscitation. We went on to do a CT angiogram on 11. This case has happened in 2017. So we did the CT angiogram where we can see this is a celiac axis. This is splenic artery, no issue. This is the common hepatic artery, and this is a GDA stump. The GDA stump is actually, it is patent. There is no leak from the GDA stump. And we can see when you trace the left gastric artery, we can see an aneurysm at the left gastric artery. It is actually one accessory left hepatic artery was there. So it's the origin point of this accessory left hepatic artery. We have got a pseudoaneurysm. So immediately we thought of that pseudoaneurysm is the cause of bleed. So what we did is we did the angioembolization of this. So this is a left gastric artery pseudoaneurysm. This is accessory left hepatic artery. So we did a coil embolization of the left gastric artery pseudo. So this is a pseudoaneurysm, and this is proximal and distal to the pseudoaneurysm we have embolized. But still the patient continued to bleed and had hemoglobin drop again. So we thought of, have we missed something? Is there any missed pseudoaneurysm was there? So we did a review of previous ECG. It yielded no valuable information. So a repeat angiogram was done on the same night, So this is a repeat CT angiogram. So you can see this is the left gastric artery coil, which we have already embolized. When we coming down, this is a common hepatic artery, and at the end we have got the GDA stem, and there is an active contrast extravasation from the GDA stem. So again, the patient, this is a GDA contrast extravasation. So again, we have taken up the patient for angioembolization. So on the same night, we have done the repeat angioembolization. So this is a initially already embolized left gastric artery pseudoaneurysm. This is a common hepatic artery we have cannulated, and this is a GDA stem, and we have embolized the GDA. So this is a coil in the GDA stem. So coming back to our patient number 1, is the rebleed from our patient is also from the same aneurysm, or is it a new aneurysm, or is it a missed pseudoaneurysm from different vessel from it was there from initially itself? So we were in thinking of that term. So meanwhile the hemoglobin has came. It was actually 8.5 because it was 11 before, and there is a major bleed has happened. So we were thinking of doing another CT because it has happened almost 10 days after the second admission. So we did a repeat CT angio. So this is a repeat CT angio. When you take the repeat CT angio, this is a PJ loop. In the PJ loop, we can see some hyperdensities. That is actually the blood. And when you trace down, we can see this is a pseudoaneurysm, which is a jejunal branch pseudoaneurysm, which is actually exactly similar to that of the previous aneurysm. And we can see a small active contrast extravasation into the PJ loop was also seen in this CT. So we thought of again risk versus benefit, but now we can't wait because the patient has been bled again. So we have to deal something. So we proceeded to go ahead with angioembolization. The hope that already 18 days has been over after our phase procedure. So there must have been some new collaterals must have formed. So we go ahead with the angioembolization. So this is the angioembolization. Initial angioembolization itself really this is a second jejunal artery we have catheterized, and there is active contrast extravasation was there, and we finally get to know the coil embolization has been done. So if you do this coil embolization artery as a whole, that's the only available option. So the check angiogram, we can see that there is no flow. What I show in the initial CT angio, that vessel has completely obliterated, there is no flow. But when you carefully observe, you can see there is a small collateral vessel was there, which was bleeding, which was giving branches to that area of stapled end. So now the time is ticking. We have to address two issues. One, we haven't addressed GDA in this, even in the second angiogram, we haven't addressed the GDA. So is there any chance of rebleeding? Have we missed some new aneurysm, some other aneurysm? So is there any chance of rebleeding? That's the first question we have to address. And the number two, is there any chance of this bubble ischemia? So if there is the rule limb of that jejunum is gone into necrosis, then it can cause pancreatic leak, fistula, and its own complications. So the time is ticking. We were in also dilemma. So on the POD 19, that means the next day of procedure, patient has got some vague abdominal discomfort. Pulse rate was only 110. Pulse rate is around 110. Abdomen is absolutely soft. The hemoglobin is 8.8. It is after one PRBC transfusion. The hemoglobin is 8.8. The counts were 18,000. The patient is on broad spectrum antibiotic. We kept her in STU itself. On POD 20, that is the next day, again the abdominal discomfort is persisting and the tachycardia is still there. The patient has got one episode of fever, but her urine output is adequate. HB is maintaining, but the count is increasing. It has gone up to 27,880. On the next day, by evening, the patient had one more episode of blackish stool, which we cannot characterize as melena, but the patient has got one more episode of blackish stool. So we don't know whether is that collected blood is going, we don't know. Whether is it a new bleed, again, we don't know. Or is that the ischemia of that small end of the bowel, so that the mucosal ischemia, which will present as, which can also present as melena. So is that has got? So we have got a confusion. So we did an SP, there is no fault. That means we have ruled out it cannot be collected blood or it cannot be a new bleed. So her vitals were stable apart from minimal tachycardia, and there is no fever. Abdomen is absolutely soft. So finally, almost 21 days has over after the surgery. The patient is in the hospital for more than 2-3 weeks, and the patient also got some sort of depression. Her mental status has become somewhat depressed. So we have to end this dilemma. We have to end this. So is there any ischemia in the ruin of the pancreatic jejunectomy limb? So we thought of doing one more CT, which is again the third CT in her 20 days of hospital stay. So this is a third CT just to rule out is there any bowel ischemia, but we can see the bowel wall is well enhancing. There is no ischemia and there is no new pseudoaneurysm. This is a coil in the old pseudoaneurysm. There is no new pseudoaneurysm, no new bleeds. So we were relieved and we continued the supportive management. So on over the due course, her hemoglobin has been improved and her total counts has been decreased. Again, it has improved, and the average pulse rate also has become something around 90 to 95. And on POD 28, that is on 25th of November, the patient doesn't have any symptoms. She passed normal colored stools. She is orally tolerating, vitals were stable, abdomen is absolutely soft, no further episodes of melena or drop in hemoglobin, and she was discharged. So after an eventful recovery, an uneventful first discharge, and after that there is an eventful hospital stay, then we have discharged. So that is about the patient number 1. Then one more patient, it is a patient number 3, is a 64-year-old male, is a non-case of type 2 diabetes and systemic hypertension. He was evaluated for history of painless progressive jaundice for 3 weeks and weight loss of 2 months, diagnosed to have carcinoma head of pancreas, and he underwent Whipple pancreatic duodenectomy. There is a 3 into 4 centimeter pancreatic head growth. And it's a firm pancreas with an undilated neck. There is an intermediate risk of POPF is there. The issue happened here is in the postoperative day 1 itself, there is a hemorrhagic nasogastric output from early morning, around 250 to 300 ml has came. And it is associated with the hypotension and fall in hemoglobin. So a resuscitation started. So we were thinking of is endoscopy, because it is a fresh blood, is endoscopy has got any role? But question is, it is a early bleed. So if the endoscopy did, there are 2 anastomosis. There are anastomosis like gastrojejunostomy or pancreatic jejunostomy. They can disrupt. That is one. Number 2, in cases of active bleeding, if there is blood clots are inside the stomach, we may not be able to identify. We may not be able to localize the bleeding itself. So that is the opinion. That was the same opinion as similar to that of our endoscopist also. So the patient is deteriorating. He is on hypotension, hemodynamically unstable. So we pushed him to OT for emergency re-exploration. So this is what in the relaparotomy, there was no active bleeders were identified extraluminally. So apart from the, along with this, we did an intraoperative endoscopy. There is only dilated stomach with the large clots were there, which actually limited the visibility. And we could able to identify some small clots were seen at the GJ site, but all other pancreaticojejunostomy, hepatico and JJ looked healthy. So what we did is we opened the anterior layer of GJ. The clots has been evacuated, stomach wash given, and after ensuring hemostasis, we do a redo GJ, by which time the patient was quite stable hemodynamically, and then he was shifted back to ICU. But after re-exploration, the patient was stable for only 12 hours. And after that, again, there is persistent hemorrhagic nasogastric output with the hemodynamic instability and low urine output. So initially resuscitated, and what to do next? So whether to re-explore again? No, there is no use, because initial re-exploration also didn't yield that much of finding, and we can't do a re-exploration in the next within 12 hours. So that option is out. Can we wait and watch? Again, the patient is deteriorating. The patient's hemodynamic stability has come down. So can we wait and watch? No, the answer is again no. Then the only conventional option is it's a conventional angiography. So we did the conventional angiography. So here we can see this is a conventional angiography where we can see there is 2 branches are arising from the aorta. This is a splenic artery, and this is one left diaphragmatic artery, and the left gastric artery was arising from the left diaphragmatic artery, and we can see an active blush, an active contrast extravasation from the left gastric artery, and that extravasation is into the bowel. So what we did is we did a coil embolization of selective cannulation of left gastric artery with the coil embolization of that aneurysm has been done. So post-procedural, the patient has been shifted to SICU, hemodynamically stable, but with the maintained urine output. But he continued to have bleed for altered blood in the nasogastric tube for 3 more days, which was again managed conservatively. And the general condition has been gradually improved with FJ feeds and higher antibiotics, and was gradually progressed to orally, and he was discharged later. So I would like to convey these learning points of my patient number 1, the female patient. The pseudoaneurysm can happen in unusual locations, which can create dilemmas and havoc in management. So why we waited for POD 18? Because the waiting probably allowed some collaterals to develop and avert the bowel necrosis. And then our patient number 2, that is the two aneurysm. The pseudoaneurysm can happen in separate vessels and can even present within hours of interval. So that is how the importance of addressing GDA, even in the first or the index angiography itself, the role of addressing the GDA, because GDA is the most common location of pseudoaneurysm. So probably better to embolize GDA in all the cases of pancreatic bleed is one protocol which is the department is following. And in patient number 3 is basically the general rule is re-exploration for early bleeds, but the exception is early pure intraluminal bleeds, and that can be tackled with a conventional angiogram. But if it is, as we all know, if it is an extraluminal bleed with a hypotension and all, we have to go with an alternate age of explore, and it's continuous. So coming to finally, the take-home messages are when not to intervene, when to intervene, and how to intervene is an actual dilemma in these scenarios, which requires a dedicated team approach after analyzing the risk versus benefit. Pseudoaneurysm following pancreatic surgeries can happen in unusual locations, unusual timings, and the CT angio followed by conventional angiogram plus or minus angioembolization should be the ideal initial mode of management, and a dedicated interventional radiologist is a must in pancreatic surgery team in order to reduce the morbidity and mortality following the pancreatic surgery. And before concluding, this is actually a feasibility of multi-institutional data collection analysis on post-pancreatic surgery hemorrhages under the guidance of ASCK. Is that possible? Is one question we have to address. And thank you.
Thank you, Jasil, for sharing your experience in managing post-pancreatectomy hemorrhagic bleeds. I really appreciate the way the cases have been managed, and especially the first case, you did not give in to the temptation of going in and embolizing a small jejunal aneurysm. There was a learning point there, because these vessels, if you embolize, especially with gel foam, there is a very high risk for bowel ischemia. Yes. So not giving in to the temptation of going in for an early embolization, I think was a good strategy. A good learning point there. The second case I thought was more of a conventional case, GDA aneurysm, left gastric artery aneurysm. Coming to the third case, before I invite comments from all the other participants, I was just wondering that if you have an early nasogastric tube bleed, I would have thought of doing a CT before going in, unless the patient is really unstable. So you did not go ahead with a CT, probably because the patient was unstable, isn't it?
Yes, sir. The patient was on the post-op day, one day early morning itself, the patient went into hypotension on supports. So he was actually become hemodynamically unstable. So the only option to left is we have to do some sort of intervention before.
I completely agree with you on that point. But only thing is, CT gives a lot of information. Sometimes you explore and then you don't know where to look for. So CT might be a roadmap on what to do. What you could have excluded certain things, but absolutely okay. That's a clinical decision that you take, especially when the patient is in hypotension. So with these few comments, I think I would like to invite comments from all the other participants. There are a lot of senior surgeons here today evening. So can I invite the other participants to come and give their comments? Shubhalal sir is there. Shubhalal sir.
Yes, thank you, Dinesh. So my concern is when you do an angiogram, do you do only celiac? Why can't you do the superior mesenteric artery also? Because we are doing some anastomosis with the intestine. As in one of the cases, there were two aneurysms at different sites. But they stop with one celiac or one aneurysm, one angiogram, and if they see some pseudoaneurysm, they stop there, or they do the other.
The routine protocol here is our interventional radiologist, and as per our department protocol, we usually do all the two vessels, the celiac and the superior mesenteric artery. We will do, sir.
So both were done in all the cases.
Yes, both were done in all the cases.
So the second aneurysm developed later.
Yes, sir. The initial angiogram does. Then in the second patient, the initial angiogram doesn't really reveal the GDA aneurysm. GDA was a GDA pseudoaneurysm. GDA was, there was no extravasation from the GDA. So that's why it was not tackled initially. But the patient has rebleed in 12 hours, within a span of 12 hours. Then again, we did a repeat angio, then that showed an extravasation from the GDA.
So pseudoaneurysm bleed should be the first diagnosis, I think, after pancreatic surgery. Every one of us has experience. I remember one case when I did the nipple in medical college, maybe 20 years back. Then the patient one night developed with a massive bleed, and we don't have that angiogram facility in medical college. We had to take the patient to Sriyatra. I think Dr. Arun Hemal was my PG then. He took the patient and to the Sriyatra and took the angiogram. There was an aneurysm, I think it in the hepatic artery, one of the branches. So embolization was done and the patient was saved. So always you think about pancreatitis, acute and chronic. In chronic pancreatitis, there may be pseudoaneurysm which may not bleed. They say about 2 to 16% may have pseudoaneurysm, but without bleeding. That is one interesting finding in chronic pancreatitis. Always think about pseudoaneurysm bleeding, which can be managed most of the cases with the embolization. And save the patient. And timely diagnosis, timely intervention, what to do, when to do, etc. Actually, pointed out is very important. Thank you.
Thank you, sir. Dr. Ramesh?
Yeah.
Dr. Ramesh, in the first case that was presented, the patient had an uneventful postoperative period. And then the jejunal artery pseudoaneurysm.
Dr. H. Ramesh, probably. You mean you are
No, Ramesh Rajan.
okay. He is still in transit. Okay. HR is
No. I was just wondering, Dr. Ramesh, in the first case, uneventful postoperative period, the patient presents with a small jejunal artery pseudoaneurysm. What could be the cause for that?
Yeah, I am a little, that is what I was planning to raise that point to Jazeel. So, because in chronic pancreatitis, the patient very atrophic gland with a classical tropical pancreatitis with large stones. So we expect the gland to have burnt out with very little activity, but it's surprising that the activity need not correlate with the size of the gland and the stone size. Yeah, but it is not very common. Actually, I think if you look at literature also, these things, the pseudoaneurysms are more common in pristine glands or those who undergo Whipple's rather than for chronic pancreatitis.
Yes,
Just out of curiosity, some people routinely take the pancreatic fluid, duct fluid for cytology and amylase. Was it done in this case, or just out of curiosity, just to see whether it correlates?
No, sir, we didn't did that. Only the drain fluid amylase we have did. Otherwise,
No, on table.
No, sir.
Yeah, okay.
We will send it for culture, and that's it, sir. Otherwise,
not cytology or
no, not cytology.
Okay.
The head coring specimen we will send for
frozen. Yeah.
Frozen.
But could it be that the first case, there was no leak at all, and this could be just because of a technical thing of taking a ruler?
Maybe a surgical injury to the tunica or adventitial layer of that vessel, because it was the content of that jejunal limb, the roux and by the content of the jejunal limb. So maybe the vessel is part of some sort of minute injury or something. But that may be the reason for pseudoaneurysm.
And it is also surprising that it was actually on the very near the lumen, right?
Yes, sir. Yes, sir. It was very near the lumen.
It was purely an intraluminal bleed.
Sir, I didn't get, sir.
It was a pure intraluminal bleed.
Yes, sir. It was a pure intraluminal bleed.
Yeah. That is again.
Maybe because of additions that can happen.
Yeah, maybe. And the other case also, I just wanted to ask.
Yes, sir.
Is it all that common to get a pseudoaneurysm bleed on POD1, like within 24 hours?
Sir, it was actually not a pseudoaneurysm, sir. It was an active extravasation from it was injury of the vessel and then extravasation from the vessel, not a pseudoaneurysm.
Maybe something related to the suture line, staple line, something near this.
Yes, sir.
Right. Anyway, very well managed cases. Yeah.
Thank you.
Dinesh, I think Bijoy has raised some questions.
Is it?
On the chat.
Sorry. I mean, on the chat box, is it?
Yeah.
Okay.
And Dr. Prasad has raised a hand also.
Can I ask question, Dinesh?
Yeah, sure. Please, Prasad.
Actually, a very difficult case. It's a difficult situation for both the surgeon and patient. All the three cases beautifully managed. And I agree with Dr. Dinesh, if possible, as in the third case, if we can do a CT angio, it would be better, because sometimes we open, we won't see anywhere bleed, and sometimes we might have to close it. So actually, I just want to ask regarding, so what is the thing, how can we avoid a bleed? Is it necessary to ligate the GDA in chronic pancreatitis or phrase procedure? Second question is that 18 days, how do you come to a conclusion that collaterals will develop in 18 days? Or sometimes what will happen after, is it okay to do a distal pancreatectomy or something in a future case if the distal portion is ischemic? These are the two things I want to clear.
The first question is, as the routine department protocol is, we will ligate the GDA in continuity. Usually in the all the chronic pancreatitis cases, we ligate the GDA in continuity. We will just ligate. We'll just take a deep suture with a proline, and we will just ligate it. We won't divide it. That is one. And the second thing, actually, sir, we have got the resources for conventional angio. We can go ahead with that, and if we can control the bleed, and then if some complications can develop, we can go ahead with the laparotomy, and we can do the distal pancreatectomy.
Well, I'm just asking your any literature review that the collaterals will develop in so many after 2 weeks, 3. Do you have any literature review on that?
Actually, there is no literature, because the 18 days has already gone by. There will be a lot of additions, and because of some minute inflammation, there will be neoangiogenesis will happen. So the neoangiogenesis can happen within a span of 5 to 7 days. So that was just a blind guess, sir, from all the team members after discussing with all the team members. And also it was well evident by the second angio, second conventional angio, showing there was a small collateral was actually formed. It was not there in the first conventional angio.
Jasil, there's a very interesting question from Dr. Bijoy on the chat box. It reads, is it possible to use gel foam for temporary control of bleed from jejunal vessels and possibly avoid bowel ischemia? So, I mean, I'm not an expert, but my feeling is that it is more dangerous to use gel foam, because the particles will flow into
particles can actually embolize. Particles can.
So they embolize, and the risk of ischemia is higher. That's what I understand. I mean,
higher in gel foam. That's what
much higher in gel foam. And the problem is, if you use gel foam, the ischemia is very subtle. The patient may not manifest, and then suddenly bowel ischemia, sepsis, and you may completely miss. So I think one should be wary of using gel foam. Dr. Ramesh or any other senior, Dr. Sindhu, if you have a opinion on this.
Yeah, I would opt for gel foam, although it says that it can recanalize, but it can go distally. So even if you use gel foam, I think they always combine it with the coil so that it stays within that segment. If they use gel foam alone, it tends to go distally. It tends to go to the distal small vessels. But of course, it may be temporary. It can recanalize. But in that time period, it does go into the distal vessels.
Jasil, there is a question in the chat box from Siddharth Chaku. This question is, what happened to the CA99 in the first case? Did it come down? If CA99 is persistently high, what do you do?
Sir, actually, the patient was actually discharged 5 days back only. So he has to come back for the review. So we'll repeat that CA99. If it is still persistently high, maybe because of the inflammation. The previous initial months, it may be because of inflammation. If it is still high, we can go ahead with some EUS to assess some missed mass lesions as per the CT. So I think we will repeat the CA19 once the patient come back for the review. Maybe she's due on Monday, I think. So Monday she will come back and.
That's my
Hi, Mahesh.
Dinesh, can I answer that?
Sure.
Actually, for this particular patient, that head covering specimen was actually sent for a biopsy. It has come as negative. It's quite unlikely that the patient is harboring a malignancy for this in this gland. Anyway, we'll follow her up with the repeat CA19 whenever she comes up for repeat.
Mahesh, one query. Jasil was saying that you routinely ligate the GDA.
Yeah.
So, I mean, just a hypothetical situation, you ligate the GDA and then the GDA develops a pseudoaneurysm and then there's no neck to embolize. There's a large pseudoaneurysm arising from the
In
GDA.
continuity.
We do it in continuity and we'll make sure that there is a stump to
right.
address it.
Okay,
Whenever,
right.
if at all it develops a pseudoaneurysm.
Okay.
Dinesh, one question from Sular.
Sir,
Suppose all the diagnostic modalities do not show any reason for the bleeding. What will you do? Your CT angiogram or conventional angiogram, all those things are negative. What will you do?
well, sir, that's a very good and a difficult question to answer. But my feeling is that many a time in such situations, one should think about the rule loop and the jejunojejunous. If you have taken a rule loop, if there's another anastomosis that is bleeding. Sometimes it may be one of the anastomosis that's bleeding, which may not show up either on the angiogram or on a CT scan. Then I don't know. Usually we have to be conservative, I think, if the patient is stable. And these patients will undergo many.
Anastomosis means another laparotomy surgery.
Pardon, sir?
Another anastomosis means second surgery, another surgery.
No, sir. Sometimes when you investigate it, you can't find a cause for the bleed. I was just wondering, can it be from an anastomotic site? It may be the GJ, it may be a HJ site, a persistent bleed from one of these sites. And sometimes if you take a rule loop, you can have a jejunostomy site bleed. And then it's very difficult to tackle and one may have to even re-explore. I mean, we have come across a few cases where jejunostomies have blood. And there's no way you can manage it. You transfuse, you investigate, repeat CTs. And then sometimes an RBC scan may pick it up, but you end up operating. I don't know whether I've answered your question, sir, but this is one situation that I think is possible.
Yeah, in some of the, I think I read somewhere that you have to think about alternative cause of bleeding, like some other disease, associated disease, which is there, which you have missed. That can also happen, but why can't you repeat the angio?
Yeah, we can. Yes, that's one option.
Okay. But that can, you have to think about this situation. All your investigations may not produce any source of bleeding. That can happen.
Dinesh, can I?
Yes. Yeah, please.
Point. I think Jasil, are you here? Did you mention that in all post-pancreatic bleeds, especially I think pancreatic duodenectomy, your policy is to coil the GDA always?
Yes, sir. Actually, it depends upon case by case. But after the experience of that case, we usually embolize. The department protocol is usually go ahead with the empirical embolization of GDA stem. That is what we usually practice.
Okay. But that probably if there's a GDA stump leak, there always has to be essentially, I mean, always for a massive bleed, there should be blood in the brain, I suppose.
Yes, sir.
Correct?
Yes, sir, that has to be there. But maybe that's mainly because of the because if even if one bleed has happened, the GDA can bleed in later on any day. So again, a repeat angiogram, repeat conventional angio may not be a good idea. We have to do that, but if we can tackle both of them in pre-operatively, I mean on the single setting as an empirical embolization, that will be a better thing for the patient. We can avoid the morbidity.
And Jasil, if you do an angio and you find that there's no neck, there's a large GDA aneurysm, no neck.
Then we will go ahead with the covered stent graft. We will place over the stem, so that the aneurysm and that has been excluded from the main list.
Another point, Dinesh,
Yes.
radiologist was suggesting that, as the point raised by Shublal sir, that sometimes when you do an angio, you may not find anything. It may be a negative. That there is bleed. So there is an option of keeping the sheath there and coming out.
Okay.
You think that the patient is still bleeding. So the next bleed, you can go in faster. They can go in faster, and you really think that the patient is unstable.
What is it, Ramesh? Option of what?
Keeping the access sheath for the radiologist. Now, somebody was suggesting, some radiologist was suggesting once that the puncture sheath, no, sir.
Conventional angiogram puncture.
And for the conventional angio, yeah, conventional angio.
The other thing is that all these cases, fortunately, has happened in-house when the patient was in hospital, and when the discharged patient also came in reasonably stable. But sometimes what happens is the bleed is massive. The patient is unstable, hemodynamically unstable, and when they come into the casualty, they are on inotropes. And when you do a CT and then go ahead with an angiogram, you find that the entire mesenteric vessels are in spasm. And this is an extremely bad prognostic sign, because these patients you will coil, you will get hold of the aneurysmal bleed, but subsequently the lactates keep rising, the patient will develop a NOMI, and there is a very high risk for mortality in these patients. So it's an extremely bleeds following pancreatic surgery are, they present in many ways, but some of them are extremely dangerous and can be life-threatening, even after controlling the bleed.
True, huh? I agree very much.
Is Dr. Joshi around? Dr. Joshi?
Sorry, I had a call from hospital in between, so I couldn't follow the discussion entirely. But I understand that this it's a problem which we all face, and the 3 cases were managed well. And I think nothing much to add from my side.
Thank you. And Pitambaran?
Well managed, very good cases. Only thing is that what I was just thinking, what is the real role of doing the routine ligation of gastroduodenal artery in a phrase procedure? Whether it adds to the injury, or whether it can precipitate pseudoaneurysm in a otherwise normal phrase procedure. Because we don't see usual bleed from the GDA in a phrase procedure.
Actually, we tend to do that, but not actually ligate. Not ligate it proximally, but near the pancreatotomy, close to the pancreatotomy, we just oversew it in such a manner that you don't take bites through it.
Yeah. Okay.
I think
sometimes the line of
pseudoaneurysm part, ligating this GDA actually reduces the bleed during this scoring procedure.
Yeah.
That actually is because that usually so the less blood loss during the head coring procedure. I think that is one thing which would be of advantage to the surgeon.
Yeah, but I think Joshi, again there you need to do it quite close to the line of pancreatotomy. I think.
Only then the bleeding will.
It's not very useful if you ligate it very much. Go and ligate it proximally.
Yeah.
Do it close to the pancreatotomy.
We have Dr. Sindhu with us. Dr. Sindhu. Hello.
Hello.
Dr. Sindhu, hello. Hi. Dr. Sindhu, would you like to add your comments? You have a lot of experience with pancreatic surgery.
Actually, we have a publication from Trivandrum on empirical embolization of splenic artery. When you cannot identify the actual bleeding site. Actually, we didn't had any further episodes of bleeding in that series of cases. That is like a procedure we have done.
Correct. I forgot to mention that. It's good that Sindhu brought it up. Yeah. Srijit did the work on that, and that was published early this year.
Okay.
Srijit, I think Srijit is also here. Is Srijit is attending?
Yeah, Srijit is around, yes.
Srijit is here, I think. So what we have done there is that it is not palatable to many people. We have done that. We have gone ahead with empirical embolization of the splenic artery in cases which had dunking, in patients who had dunking, but not for phrase. This were ripples, and patients who had dunking and had pure intraluminal bleed. Okay, you do an angio, you don't find anything, the angio is negative. So you empirically embolize the mid segment of the splenic artery, called the mid segment of the splenic artery, which is the dorsal pancreatic, the segment which gives out the dorsal pancreatic and the main pancreatic branches, such that the branches are left behind. I think Srijit is here. Srijit, you want to?
Yes, sir. Yeah, so like it was like 9 case scenario. Like, I think
Srijit, your voice is breaking.
Connection, I think.
Yeah, it was like it was like 9 case scenario. Like 5 was post Whipple's procedure, and like 1 was acute pancreatitis, 1 had a lateral pancreatic stenosis, and 1 case had a failure, so which we had to proceed with distal pancreaticosplenectomy. All else were successful. So I think for intraluminal bleeds, when like the CT angio and the conventional angios didn't reveal any significant pseudoaneurysms, and we had high suspicion that it was a intraluminal and maybe from the cutter to the pancreas, maybe this modality would be of use.
Yeah, for pure intraluminal bleeds and especially for dunking.
For dunking.
So 6, you said 6, correct? 6 out of 7, correct?
Yes, sir. Rather 8 out of 9. I think.
Yeah. But among the pancreatic duodenectomy was 7, I think. Out
7,
of
yes.
which 6 had successful angioembolization.
Yeah, 1 we had to go for
surgery. Yeah. So this was published in Indian Journal of Radiology, accepted this year, correct?
Yes, sir.
We had a lot of discussion with the radiologist. I think the first case was done in 2012 or 2011. Am I audible?
Yes, you are.
So before embarking on this, there was a lot of discussion with the interventional radiologist, ifs and buts, and whether the spleen will get whether we lose access, further access, there is a rebleed and all those things. But it was almost like a do or die situation. So, the radiologist also agreed that the pancreatic, the pressure may reduce if it is a pure intraluminal bleed, and if it is a dunking procedure. There's no peritoneal bleed at all. There's no blood in the drain at all. And it's a negative angio. So finally, we had to take a call. And I think 2011, we did the first case, empirical embolization, and it was successful. Actually, he just stopped bleeding. The patient never rebled, and he's still alive.
There were actually concerns regarding necrosis of the pancreas, splenic abscesses.
I think
but we didn't have any case of no complications with regard to the pancreatic necrosis or even splenic abscess.
Dr. Ramesh, why is it just for dunking procedures? Can you think of other procedures, ductal mucosal anastomosis?
No, ductal mucosa, if there's a significant bleed from the stump, from the cut end, some blood, you expect blood to come out into the peritoneal cavity, correct?
Okay.
Whereas if it is dunking, it is likely to be more intraluminal. Of course, it can anastomosis leaked, it can distort and come. But if it is purely intraluminal, it is more likely to be from the pancreatic stump rather than from GDA.
Okay. Thank you.
So,
Point,
if we do not have
one more point there was that Srijit was talking about whether it will undergo necrosis. That is what one concern which the radiologist also expressed initially, because you're blocking of everything. But I think pancreas is a very good rich and the terminal most branches near the splenic hilum are spared. In all these cases, the terminal most branches near the splenic hilum have been spared. And I think it is the anatomy, they describe about some small branches coming from the SMA to the entering the inferior part of the pancreas. There are some small branches from the SMA entering the pancreas. I'm not sure of the names, but that's it. So nothing happens.
right.
The pancreas doesn't become ischemic.
Sir, how much mobilization of the pancreas will you do for dunking? How many centimeters?
About 5 centimeters, 4 to 5 centimeters. About 3 centimeters would go easily inside. You do about 4 to 5 centimeters, about 3 centimeters goes easily inside.
So, are there any other questions? Dr. Pidambaran, I think if there are no further questions, I think we should thank Jasil for all the good cases that he has presented. There were learning points in the cases, and there has been good discussion, especially the last part of the discussion about splenic artery embolization when you have no other options. And I was not aware of this. Probably this is something which we can try, especially with the Trivandrum Medical College experience. I mean, in dire straits, I think we can suggest this as an option. I was not aware about this.
I could suggest Srijit to share it in the ASGK group.
Okay, right. I think
Yes,
we'll
I
find the
will do
paper
that.
and read it.
Yes, sir.
So, if there are no other questions, should we say good night today and meet again?
Yeah, I think we can wind up the session. I think Dr. Ramanathan has not joined today. I think he usually winds up with his.
Okay.
Okay. Anyway, thank you, Dr. Jazil and Dr. Mahesh and the GS Surgery Department from Lakeshore for presenting this good case. Well managed 3 cases. Good discussion. Thank you, Dr. Dinesh, for chairing the session. It was a fairly good discussion. I think a scenario which most of us who do pancreatic surgery come across. And there are still a lot of doubtful areas, how to go. We all come across this problem fairly frequently. So a fairly good discussion. And thanks to Dr. Pidambaran, the evergreen hero who is managing this ASGK Grand Rounds monthly once again. Thank you all for your active participation. So we'll end up the session. Thank you all. Good night.
Thank you.
Right.
Bye.